Dr. McCullough is an emeritus professor of clinical psychology, and since his retirement in 2017, he actually spent his 48-year career at Virginia Commonwealth University in Richmond, Virginia. His career was divided between doing research with chronic depression, treating chronically depressed patients, and teaching graduate students in VCU's PhD clinical training program. He developed the only psychotherapy program in the world designed to treat the chronically depressed patient, which he defines as we do as well, persons depressed for more than 2 years. His treatment program has gained worldwide acceptance in the United States, Europe, and Asia. His diagnostic research also contributed to the acceptance of chronic depression as a distinct diagnostic category in the APA, the DSM-5 in 2013. He's written 6 books and published numerous psychological publications. He continues to write, see patients, and supervise professionals treating chronic patients in the United States and Europe. Dr. McCullough has been married to Rosemary Fleming McCullough for 59 years, and they have 3 adult children and live in Henrico, Virginia. And just wanted to suggest that for Dr. McCullough's talk that you can go to the view section on the top right hand of the screen and select the side-by-side speaker option. And that way you'll be able to see Dr. McCullough speaking as he's going through his slides. He'll be mostly just using the slides as a little bit of a stimulation for discussion, but he'll mostly be just talking and having interaction with the audience. And he's going to start us off by asking us to respond to a question that he's going to ask. And you can either just unmute and respond, or just put it in the chat function what your response is to the question that he'll be posing us. So Jim, with that, I think I'm going to turn it over to you, and yeah, take it away.
Thanks, Brant. I'm delighted to be here with you all. It's the first time I've been out in Santa Fe in a long time. I wanted to ask, and I think Brant has explained how to split the screen and enlarge my speaker screen if you want to. But I'm going to talk about the therapy model, and mostly about the early onset persistent depressive disorder patient, probably one of the most difficult. I think the top of the line patient is the borderline. Marshall Linehan wins that contest. But this one is a near second, early onset persistent depressive disorder adult. And I've been working with these patients for almost half a century. And on the slide, you see there are 3 books listed, and I will send Robin Brenniger copy of the slides after the program is over. And if anybody's interested in reading a little bit more about CBASP, you can do that. So with that said, let's take about 5 minutes, and Brant's going to help me out here. And all of you have seen chronically depressed adults. Can you give me some one word or a couple of word suggestions about what your personal reactions have been to sitting with, treating these early onset chronically depressed adults? And with that, you can either use the chat or the audio if you'll unmute yourself and give me some idea of what your reactions have been with this patient. That will help me a lot. And I'll turn it over to you to react.
Thanks, Jim. Well, I'm going to monitor the chat, and if folks just want to unmute and speak up, you're welcome to do so. So far, there's chats coming through. Exhaustion, frustration, frustrating, challenging.
Wait a minute. Exhaustion, frustration.
Exhaustion, frustration, challenging, resigned, helpless, a challenge.
I'd say draining.
Draining.
Good. That's a big one.
Demoralizing. Yeah, y'all are welcome to keep the responses coming. Yeah.
Anybody else?
Another vote for draining. Feels helpless.
You talking about the therapist or the patient?
I don't know. Jennifer, are you talking about feeling helpless as a therapist, or that the patient feels helpless? Yes, as a therapist.
Sounds familiar. Okay.
Defeated. And
What was the last one, Brent?
defeated.
Got it.
And then somebody added, Will Wiley added, feeling helpless as a clinician, although I'm noticing a lot of parallel process here. And Jessica Cave mentioned, makes me feel emotionally exhausted.
Let's take a few more if you got them.
Yeah, keep them coming, y'all. Go ahead and just chat it in or unmute and share. Shelley shares feeling ineffective as a therapist.
All right. Let's cut it here. We
Okay.
got enough to spend the next couple of years working on this, so we frankly don't have that much time. All right. But I really appreciate you for laying all this out. Exhausted or exhaustion, frustration, challenging, feel resigned, helpless, draining, demoralized, helpless as a therapist, defeated, feeling helpless as a clinician, emotionally exhausted, ineffective as a therapist. Welcome to the club, gang. I've been seeing this patient for almost half a century. I've treated over 500 of them and been in clinical trials with over 2,200 of them, and they're a mess. They're a mess and very tough, but I appreciate your responses. And let me spend the rest of the lecture trying to make sense out of while he pulled all of these kinds of reactions from you. They're masters at it. They're masters at it. Let's jump in. CBASP is an interpersonal model of treatment, interpersonal. CBT, I do something to the patient. It's one way. Psychoanalysis is one way. Gestalt is one way. CBASP, I'm in the arena with somebody who does all these things to me that you have just delineated. It's an interactive, interpersonal model of psychotherapy, which means everything the patient does affects me. . Interestingly, and at the beginning of treatment, I don't have very much effect on the patient, and I'll explain why I say that in a moment. But the patient's impact on me as the other in the room is massive. It's just massive. Secondly, CBASP is an acquisition learning model. And all of you can see this little figure to the right of B, and you're very well schooled in knowing what it means. It's an acquisition learning curve. You move from left to right and across sessions. What I'm trying to teach the patient goes from zero learning, nothing. They know nothing about what I'm about. So over the course of treatment, their learning curve increases and finally maxes out across sessions. And my average number of sessions is 31 sessions. And CBASP is based on an assumption that I think as we go along will make more sense to you than it does right now. You don't change the way you think and behave, you stay depressed. So I'm going for the golden ring here. I'm going for the golden ring. This is my initial experience and dilemma with the patient. And this is what evokes exhaustion, frustration, challenge, resigned, helpless, all of these kind of reactions you have. This is a patient, this is an adult patient. They dress like adults, they look like adults. Cognitively and behaviorally, I'm going to argue today they ain't adults. And I would describe them using a construct. These are the early onsets, the ones who begin becoming depressed in middle school. And usually begin with an onset of dysthymia. With early onset patients, the family is implicated immediately. There's something wrong with the home or familial environment that the kid grows up in. It's a mess. Adolescents are tough and they don't get depressed easily. But in the beginning, this what I would call a preoperational patient, and I will explain what I mean by this term, preoperational. This preoperational patient is boxed in, and you are just somebody out there. And this red arrow that is reflected off of the box is your initial reaction. You are deflected. You don't get through that wall that the patient has lived with that keeps the patient separated from other people. And the real problem is that the patient's environment, the social environment, the people outside cannot inform or influence what these patients do. This is an operational definition of chronicity. If you are not affected by anything outside of you, as Mayfield said, you're stuck in a rut. You're orbiting in a circle and nothing gets in. Hence, resigned, helpless, draining, all of these adjectives that you laid out are a pull. And this patient sits there and they really are stuck for a good reason. I must say before I get away from this slide, the stuckness is a kind of detachment. Interpersonally, you're not going to get to me. I'm not going to let you. And the hostility that comes through is not necessary, can be, but not necessarily the angry response. It's, I'm staying away from you. I don't want to be with you. So when you begin treatment, you're by yourself, literally by yourself with this patient. About 75%, and this is an approximate percentage, about 75% of early onset chronic patients, 3/4 of them have onset around mid-adolescence. And as I mentioned, you're sitting with a patient and you do a history, and the depression course began in mid-adolescence. You can hypothesize with a great deal of validity and already know you had some real problems coming up developmentally. I may mention something that may sound a little bit new to you, maybe not. Children during early developmental periods, their maturational growth can be interfered with. We can go all the way back to Renee Spitz in 1925 in the Annual of Psychoanalysis, where she talks about marasmus kids. If kids are not held and mothered at a very early age, before 6 months, they withdraw and become inaccessible. And we've learned through a lot of research that severe trauma can affect maturational growth, and if it's bad enough, can inhibit it. So I'm going to argue today that what you've got sitting in your room is an adult, chronological adult, who is coming into your office with a chronic dysphoric condition and who cognitively and behaviorally functions like a 5 to 8-year-old child. The types of trauma abuse are varied. Can be physical abuse, severe beatings, or culprit sexual abuse. Emotional abuse, constant harangue, labeling of how bad you are, no good, what a failure, blah, blah, blah. And emotional deprivation, nobody really cared. Nobody cared if you came in at night. Nobody cared if you left. Nobody cared if you played athletics. Nobody cared what kind of grades you made. There was total deprivation. And it might be physical. There might not have been any food in the pantry. And an emotional deprivation. You grew up in a desert. And they come into your office expecting what? Nothing. Nothing. There's another type of trauma that I've labeled psychological insults. This is where a child grows up and a kid grows up and is the recipient of constant verbal barrage that's negative. And this can achieve severe trauma implications. So one reason, this is treatment resistant patient is and what I'm thinking about, we all assume this adult is like us. No, this one isn't. Not this one. He ain't like you or she ain't like you. And this is the hardest message to get across trainees. They ain't like you. They don't think like you. They don't emote like you. They don't behave like you. They're little boys and girls. This is a tough one. So you talk with adults, you get along fine. You got somebody different here. And this is why they're so dang treatment resistant. We overshoot them. Everybody overshoots them. And they wear us out. Okay. How come they're in this mess? Well, you know the story. Caught between mommy and daddy. And this was reality, and there was nothing I could do. The way they presented reality to me was the way it is. The only problem was the way they presented reality to me was impossible. Impossible. So I was programmed to failure, and mommy and daddy may not have meant it this way, but I was programmed to fail from the time I came out of the womb. From the way we were raised, we draw conclusions about the world. And where I differ from Terry Beck, and I know Terry Beck, or did know Terry Beck, and I've done some CBASP techniques on Terry. Terry started out treating major depression in the 60s and was a magnificent, or made magnificent contributions to our field. But I haven't just got a problem with faulty thinking or dysfunctional beliefs. I got a problem with reality as the way it was when they came up. And having an assumption, a generalized belief that people will hurt me if I have a relationship may just be based in reality. And what the heck do you do when that's been somebody's reality? So what results is extreme social avoidance and having come out of a learning background, I make an assumption that wherever you've got avoidance, behavioral avoidance, whether I won't take your medication or I won't take it the way you prescribe it, and gee, what, 51% of our patients don't take medication the way we prescribe it? This avoidance is driven by fear. And avoidance of people is driven by fear. And we got a very fearful individual here that we're sitting with. Am I painting a bleak picture? It gets worse. It gets worse. Toxic early developmental experiences with significant people in their lives, which we kind of implicated. Who are the significant others? Parents. Mommy, daddy, siblings, older, younger, kinfolks, grandparents, uncles, aunts, teachers, professors, attendings, priests. Anyone can function as a significant other and can produce pervasive interpersonal avoidance. Around this significant other, I was hurt. And how do you function if you've been hurt? You back off, or you leave, or you can fight. But most of these folks don't fight. Summary. Early developmental trauma of all types may produce cognitive, emotive, maturational problems in the chronic early onset adult. And I'll say it again. They look like you. They dress like you. They drive a car like you do. They come to the clinic or hospital. But they're very different than you are. Hard lesson for trainees to learn. And I've found the best characterization of their functioning is Jean Piaget's second developmental stage called preoperational functioning. And I'm going to explain what preoperational functioning is in a moment. And dressing and talking and appearing like you can hide preoperational functioning. And you do your best job of treatment presentation and nothing changes. And you're banging into something that means you're dealing with someone who's very different. Someone who looks like an adult, but behaves emotionally, cognitively like a 4 to 7-year-old. Had a patient once wanted a photograph taken at a company picnic. She told me the photographer took Phyllis's picture and Barbara's picture and Mary's picture, but the photographer didn't take my picture. And I said, why not? Did you ask him? No, I knew he didn't like me, and I knew it'd be a waste of time to ask him. That makes no sense. But I suggest something to you at this point. If you'll listen to the way these people talk, and this is the way Terry Beck put together his cognitive behavior therapy. He listened to his patients and he put together stylistic characteristics like catastrophizing. He listened again and again, and they catastrophized. Well, they predicted failure, and all of his components came out of listening to the way patients talk, and they don't talk like you do. If you listen carefully, it's childish talk. It's childish thinking and it's childish emotionality. I'm going to show you something here I've got under my desk. This right here is a preschool chair. I don't know if anybody has ever sat in a preschool chair lately. This is the way I try to illustrate to new trainees what they're sitting with. Imagine you're treating somebody who's sitting in a preschool chair. Now that sounds weird. That's what I found with this early onset chronic patient. And the danger in treating them is the universal problem of overshooting them. We overshoot them. We ask too much. We think they can do things that they cannot do. What did Piaget mean by preoperational functioning? Extremely egocentric. All roads lead to me. Everything leads to me. I move into a group, it's me. They cannot generate empathic functioning. The amazing thing is they can learn to think empathically over the course of treatment. And amazingly, I've found they can begin to maturate over treatment and grow up. Isn't that amazing? They can literally grow up in a zone of safety in your office. They talk in a monologue. The story they tell you is the story they told your secretary, the story they told their spouse, the story they told the grocer, and anyone else who listens. It's a monologue. It's from me to you. It's not an interactive conversation. Think of a 4 to 7-year-old child here. Pre-causal thinking. This is not your style. You think causally. If you do this, then that happens. Not this patient. So you've got a pre-logical, pre-causal thinker on your hands. We call them treatment resistant. Of course we call them treatment resistant. Our professions treat these people like adults. They ain't. They're adults, but essentially they're little boys and girls. And we got to go back and begin here. Now, I want to say IQ is not involved. I have treated some very brilliant patients. They can work higher order math. Treated one man who was an actuary at Anthem Blue Cross Blue Shield, but you put this man with a staff and you got a little boy on your hands and he was almost fired at Anthem because of some ridiculous stuff he was doing. So this is not an IQ thing. This is an interpersonal, social, cognitive, emotional thing. And interestingly, there's a time involved. They have no future. You got a future. You got a future this afternoon and tonight and tomorrow and next month. Not these people. The way things are now with you in your office is the way they've been in the past and the way they're going to be in the future. It's a circular orbit, self-contained, and persons outside that circle don't get in, and this is chronicity. This is chronicity, and it's devastating. I want to argue today that early onset adult persistent depressive disorder is more than just a chemical disorder. And the best treatment we got for PDD, early onset, chemicals, medicines, plus training this person to live differently. Plus, and not just any psychotherapy, not just supportive. I would strongly recommend CBASP. Combination treatment is the best treatment for this patient. And patients need to master, and now we're going to kind of get into some of the goals of CBASP, need to master several coping domains they've never encountered before, and they don't bring this ability to the first session. They bring all their baloney that leads you to exhaustion and frustration and challenge, demoralization, helplessness, all of it. This is what they bring to you, and this is the best they can do. They've never had an attachment figure, somebody they can grab a hold of and learn from. They've never had a safe comrade before. They're not very pleasant to be around, as you have attested. And nobody wants to be around them for good reason. Been going on a long time. What happens in a good comrade relationship? Trust. Many patients, they don't trust nobody except to hurt them. What do you do if you got somebody who doesn't know how to trust another human being? You've got a real problem on your hands. What do you got if somebody never has felt love? They can't love. What are you going to do with somebody who never has been cared for? They don't know the meaning of the word. So we're literally getting new dendrite connections in the head bone of these patients, experiences they've never had before. And that's why I said combination treatment. A pill can't produce new dendrites of trust, being cared for, protected, this kind of thing. You need both. You need both. Patients got to learn new interpersonal coping skills. They got to learn to think about what they want. And part of the treatment methodology is focusing on, what did you want in this situation? I don't know. They never have thought about what they want, much less had skills to get it. We call it desired outcomes, and they've got to learn to obtain things they want after they target what it is they want. They got to learn to ask for what they want. Doc, I can't come in Thursday afternoon. I need to change my appointment. Does your schedule allow you to do this? It's asking for what I want. They ain't never asked in their lives things like this. They got to learn how to do it. Learning to say no. No, I don't want to do that. No, I don't like that. No, I wish you'd do something else. These are skills they don't have. Basic stuff. They need to learn to experience success. I've been in therapy sessions where patients in a corporation have had success, and I'll stand up. Gee, nobody's ever done that with me before. Of course not. Nobody gave a damn whether you fell on your face or were successful. The good news is maturational problems, childhood maturation and inhibition can be overcome. It can be overcome with training that adults can go through, and cognitive, emotional growth can emerge. That's the really good news about this patient. I present a couple of sources of data for you. We did a study that was published in the New England Journal of Medicine in the year 2000. Well, Marty Keller at Brown University and a You all have heard of Keller, done some seminal work in the area of depression and in the emergent diagnostic categories of chronic depression. In our combination cell, where CBASP alone and nifazodone alone were compared, in the combination cell, we produced a 77% response rate, and that was both full response and partial response. Now, that also meant 23 non-response percent. And if I had my career to do over again, I'd focus on the non-responders in these clinical trials and find out how come they missed the train. These were 12 medical sites, 685 chronically depressed patients. I've just finished supervising a dissertation, and it's now doctorally long. Did a dismantling study of CBASP, and there are two major treatments in CBASP. One is interpersonal training, and the other is a coping skill training. And a dismantling study is where you take apart the chief components of a psychotherapy method and compare them. You administer only that part and compare it to the other part where only that part was administered and look at outcome. So we had an interpersonal training and a problem-solving training, and then a combination where both methodologies were administered. And coping training was the most effective outcome in terms of depression decrease. Interpersonal training helped some, and it's important, but it didn't have the power that coping training did. Combination training did what it was supposed to do. These are some data. The X lines are the coping lines, starting out with a BDI-2 score of 30, and there was a gradual decrease over weeks of treatment, and there were 20 sessions that all patients were administered. The box line was what happened to the patient in the interpersonal only cell. There was no change the first two measurement points, minimal change at the third, and then went back up to where they started. And you know what they kept saying to the therapist? Teach me how to deal with the problems in my life. You're not doing that. You're just talking about the relationship. And a follow-up period, we administered the whole methodology to these patients. And they said, oh, this is the other part of this method. Yeah. How you deal with life's issues. And then the combination was the diamond line. And we were really asking, does it really matter? Do these parts really matter? Yes, they do matter. And coping seems to be the strongest card we can play, but not the only needed card. And we're running out of time, and I want to summarize here. What makes CBASP different than any other therapy model that I know of anywhere is the role of the therapist, which is discipline, underline, personal involvement, where my behavior is dictated by solid clinical concern for the well-being of the patient. And I'm in the trench with them. And I get to know them, and they get to know me, and that's fine. And in that interaction, I teach them another way to live. And the goals of treatment is to move them from a pre-operational primitive way of living, treatment resistant, if you will. If you maturate, you can finally begin to think abstractly. Now, take the construct empathy. Empathy is an abstract construct. If you're able to empathize with somebody else, you can stand outside yourself and think about where they are, what they're feeling, what their reactions are. You've got to be able to think abstractly. If you can't think abstractly, you can't empathize. And that's why I said earlier, these patients can learn to empathize, and they can learn to maturate because they were not thinking abstractly, interpersonally when we began, but they are at the end. And they move from no connection, keep your distance, stay away, the beginning of treatment, to an interactive stance with me and with others, where they can go after what they need and what they want and achieve success in the process. It's change. 31 hours, what it takes me. And it's tough work, tough work. And some of you said, you're so fatigued when you see them. I wouldn't see more than 3 or 4 chronic patients a week. You may have to see a lot more than that. You see 3 or 4 and deal with them seriously, they'll wear you out. I guarantee you, they'll wear you out. One more slide. Over the years, I've found that with the early onset, adult, PDD adult, they're never cured. Never cured. And I began in the early sessions to say, look, what I'm teaching you, you got to do the rest of your life if you want to stay out of trouble. This is no fix for life. No, no, no. This is management training, and this is how serious it is. It's like diabetes. We ain't found the magic cure for diabetes yet. There are remitters, but they're few and far between. Medication, change in behavior. Absolutely demanded. High blood pressure. Wish we could find a cure, but most folks, medication and changing a lifestyle or behavior, got to do that. What do we do with diabetes and high blood pressure? We manage it, and you can live a good life. So this is what I do. Teach adult PDD patients to manage a disorder with medication and changing the way they live. And I got to have both. It's a chronic condition. It's a mess. And it wears you all out. But the good news is, with the right treatment, it can be really effective. And this disorder can be managed. And I got a lot of people's lives that I could refer you to demonstrate good management over a long time. Fran, I've come to the end of my slides.
All right, thanks, Jim.
I need to get out of this, and I have to be real careful, or I'll exit the whole program here.
There should be a button that just says stop sharing your screen.
All right, here I'm going to push this red button, and I hope.
Okay.
Okay.
I hope you don't blow up.
Stop share. All right.
Perfect.
Have we stopped? And do I need to do anything else?
No, I think we're good, and we're good for questions. I wanted to open it up for questions and comments from the audience.
Sure.
I'll first mention Dr. Richardson's comment. Dr. Richardson, would you like to unmute and sort of speak to your comment, or
Please
want me to read?
Yeah, sure. I can speak to it. Thank you, Dr. Hager. Thank you so much for your presentation, Dr. McCullough. So my comment was essentially, I find it very interesting that the DSM-5 does not include, or doesn't like really sorry, I'm got distracted by the chat, but that the DSM-5 criteria doesn't necessarily put that much emphasis on behavior or interpersonal relationships with persistent depressive disorder. And then I've always wondered, seeing these patients, I've always found them to be more similar to a personality disorder type patient. And so I was wondering if you could comment on this.
I'll be glad to comment. I want to say first, it took us 30 years to get a chronic diagnostic category in DSM. It took Keller and his work and the rest of us who were following his lead 30 years to get a chronic category, and it finally happened with PDD. This is an initial foray, and we almost didn't get PDD in DSM-5. And there were several of us who fought tooth and toenail on multiple phone calls, emails, you name it, with the chair and other committee members. And it did not come easy. It was still a specifier of major depression that was always in the wings. But anyway, and anytime we get a chronic condition, it's easy to lump it into personality disorder. But I come from an old school. You don't change personality. Personality from the old school is hardwired. That probably is not the case. But to me, we can change this. And I never thought about chronic depression from a personality perspective, because I've seen it changed and I've seen people get on track in a beautiful way. But there's not a lot of focus on interpersonal. I don't hear too many people talking about interpersonal stuff. CBASP is really a different type of therapy model. Have I answered your question? Good.
What other questions or comments do folks have? Please go ahead and chat in the chat function, or just unmute and ask.
I hope this stuff has sounded relevant to you all. I really do. I really do.
Did you have a question, Rustin?
Yeah, I'm thinking how to word it, but we started off we started this off with talking about kind of our reactions, right? And draining, exhaustion. I know that you said that you would see fewer of these patients weekly than maybe we're able to, but I wondered, this is a highly kind of interpersonal kind of therapy that you're doing, and it sounds like there's a degree of maybe not personal disclosure, but maybe I don't know, vulnerability or something in the interaction.
Go ahead and use the word personal disclosure. I have no problem with personal disclosure or vulnerability.
Yeah. I wonder with how you deal with the stress of it. in
Good
you know,
question.
after and in the session.
I don't see how you all see 10, 15 of these patients a week, and I know you do. And you give them medication and they may not adhere to the prescription, and it's the same thing every week. I'd go nuts. I'd go nuts. And I'd get me an army of CBASP therapists. Brant knows a whole lot about CBASP. I'd get me some people who could give me a hand here. And if I didn't have that, if I'm just looking at failure every week, and I've got 15 of these failures, I'm in a real jam, and I don't have any prescription for how you resolve the stress. I was an academician. I was in the university. I had the luxury of focusing on this one patient. You all do not. But out of this focus, I came to some definite ideas about a way to deal with this individual, which is what I've tried to present today. But I don't know how to tell you to reduce stress with these people, unless you've got an effective methodology.
I was even thinking even in the session, because sometimes it's so difficult with these patients, and particularly who are, like you said, so they're so help rejecting at the beginning, like you said.
Okay. From an interpersonal perspective, and I don't know what your theoretical orientation is. From an interpersonal perspective, I start with myself. What do you do to me? What effect are you having on me? And I make sense out of the interaction, beginning with myself, and then work outward with us. And with my patients, my general attitude is, I'm gonna get you. It's gonna take me a while, but I'm gonna get you. So I'm not nailed ultimately by the rejection. I kind of expect it, but I'm gonna get you. And is it Dr. Mitchell?
No, I'm a clinical social worker.
All right.
You can call me Russell.
Well, Russell, I was a chronic depressive as a young adult, and I know this crap. Nobody could get to me as a young adult. I was so sealed off, and most of my treatment methodology has come out of ways I've found, particularly with an analyst who was not a good classic Freudian analyst. He was a damn good guy who called my baloney left and right and dealt with me as a real human being. And a lot of my therapy methods came out of his work, and with other people, and with my wife and persons who've helped me get launched. But I know the perniciousness of this disorder. I smell it. And I look at these people, see where they come from, and think, I'm going to get you. If you stick with me, I'm going to get you. So I can tolerate this stuff. But if I didn't have a methodology to deal with these people, I'd probably hit the nearest bar after work ended. I'd be in a real mess. I'd be in a real mess. These people will nail you. They'll nail you. They'll nail you. And I got great respect for their baloney. But it's real baloney. It's not make-believe. It's real stuff. I've given you no answer, Rustin.
Well, I appreciate your candor.
Yeah.
Well, we're at the 2 o'clock hour. If folks
God, I'm
want
sorry we got to quit. I'd really love to rap with you all about this dang patient. I really.
well, if folks want to stay on and continue having a conversation, they're certainly welcome to do so. For those of you who need to go, please go ahead, and I'll just say thank you so much, Dr. McCullough, for presenting. And if folks want to stick around, please do so. Jim, I had this question that I think I had posed this question to you, which is there are some folks that I treat with chronic depression. It's not uncommon, actually, who sort of their defense mechanism in childhood was to develop a sense of being responsible for their parents' feelings. They kind of have this sort of the sense it's almost like a pseudo empathy, like they have to attune themselves to everybody else's needs, and yet they have a hard time really sort of positing their own needs and going after what they want. And I was just curious about how that fits into the theory and the methodology.
Let me throw out a patient's sentence to you and see if it sounds familiar. Dr. Hager, I know you've had a rough day, and we can just not have our session this afternoon, and why don't you go home, and you need some supper, and you rest tonight, and we'll just get together another time.
Yeah.
How's that sound?
Yeah. It's the distancing. It's the sort of distancing under the guise of being caring.
And what this patient's got to learn is, I want this. I need this. Can you give me this? And it's something that they never learned before. It's a skill. Nobody ever taught them how to ask or identify what they need.
Yeah.
So we start back in kindergarten. What do you want? And they've got to learn to identify what I want, and then got to ask for primary school stuff. And I deal with this stuff all the time. This is what I said. You got kids on your hands here. Good question, Brant.
Thanks, Jim. Other questions, reactions, things folks want to bring up? Chris, did you have a question?
Yeah, let me get off mute. All right, hopefully I can be heard.
You're good.
So in hearing this talk, you really emphasize that we sometimes overestimate the capabilities of some of these patients, and that they have slowed development and maturity, and that we need to meet them at the level where they're at. And I guess I wonder how you kind of assess that and how you balance it against the idea of kind of treating people at the top of their capability and sort of expecting mature behavior, and ultimately respecting their dignity and autonomy.
Okay. And I may insult you with what I say. The second part of what you say, I don't bother with. I've got to get to an individual first and make contact. All these ideas, dignity, respect. I got a little boy on my hands here. And I'm not going to demean this kid, but I'm going to have to meet him where he is. And if he has presented me with, my old man never listened to a word I ever said. In fact, he used to slap me across the room. Well, transference, you immediately know what he expects from me. And the first thing he's got to learn is McCullough is going to listen. And McCullough's not going to slap me across the room. That's amazing. But if he don't learn this, dignity, respect, forget it. That's got to get in first. But once it gets in first, things change. I can teach him how to solve issues like another adult. But I've got to get and past the barriers that he presents to me. I've got to do this. And the barriers could be getting punished for saying anything, being honest, getting punished because you should never have done that, severe punishment, having to be on time at the meals or you don't eat with military parents, saying the wrong thing with a bipolar mother and she goes berserk. And what do kids do? They shut down. So they come into me and they present me with the dynamics of what they've been raised with. I've got to get to them first. It's like, this ain't there. I ain't your mother. I ain't your daddy, but that's discrimination training, and that's got to be learned first. Then what you're saying about respect and dignity, that can be actualized. And not only actualized, can be incorporated. I got to get to the person first. Or the woman who's sexually abused. What does she expect McCullough to do? He's going to hit on me. I know he is. And that don't change quickly. Come on, McCullough. When are you going to make your move? I know it's coming. It has with every other man I've ever been with. Hey, you want some help with depression? I'll give it to you. Until that is connected, McCullough ain't going to do this. Nothing else can be done. It's like, you keep your distance, buddy. So all these, you all know all about this transference stuff. It's, I am what I've learned to be before I ever met you. And I'm going to be that with you. And to find out you're different, holy smoke. You mean you ain't my old man? No, I really ain't. So, does that answer your question, Christopher?
I think so, and no offense taken at all. I appreciate it.
Well, I hear your dignity and your respect, and I've never treated patients without respect and dignity. But by gum, they don't treat me with respect and dignity. They expect the worst from me. And I got to get beyond that. Then we can have a relationship. And it's work. It's work.
Jim, adding to what you're saying, one of the things that I learned from you is the ways in which I can make myself visible as the therapist to the patient. And then I have to become visible to the therapist in order to be able to start having an impact to the therapist. They have to be able to see me as a human being.
You're exactly right. And how do you become visible to a patient?
Yeah, and the things that you've taught me have been exactly sort of what you're getting at, the discipline
Personal involvement.
Personal involvement, yeah, like sort of commiserating with folks on something that's going difficult in their life, and then normalizing some of their experiences by talking with them about stuff that's maybe going on in your life, and doing so in a way where you're making it apparent that you're commiserating and joining, and you're also making it apparent that they don't need to take care of me.
And you have to make that explicit.
That's right.
You can't just assume they'll pick it up because they're not having to. There's a methodology in CBASP we call interpersonal discrimination. And this word discrimination is a holy word in learning. It goes back over 100 years. Discriminating. This is Daddy and this is McCullough. How many trials does it take an animal or a human being? This is Daddy, this is McCullough. It'll take a number of trials. And I take patients through this. How am I like your dad? Well, you haven't hit me and you haven't yelled at me. That's right. What have I done? Well, you've talked with me, and we go through this. One day the patient will come in. You really aren't like my old man. Took you long enough. But it's just the way we are. These connections in our brains, man, they are overloaded and over-traveled, and they bring them into you, and they play out their old games again. And how do you teach new games where you won't get hurt? You can grow up, and it's okay. And I'll cheer you along. It takes a while to do that.
Other folks, comments, questions, discussion? All right. Well, thank you everybody for joining, and thank you so much, Jim, for joining us today. Really appreciate your time.
Well, it's great being with you all. I can do this all day long. I mean, if you give me the chronic patient, I'm at home. This is what I know. But thank you all very much.
Yeah. Thanks,
Thank you
Jim.
for your help, Brand.
Yeah, you're welcome. Talk to you soon.